Assalamu alaikum wa rahmatullahi wa barakatuh. Dear friends and colleagues, this is next chapter of understanding series. Today we are going to discuss an important topic, which is the mantle cell lymphoma, deep understanding. As usual, we are going to go deep inside the pathology and the markers and the genetics and of course of the treatment of such a disease. First, we just recall lymphoma. Lymphoproliferative disorders starts from the bone marrow and from the lymph node and the secondary lymphoid tissue. The bone marrow is a primary lymphoid tissue. This is 4B lymphocyte diseases. It starts in the bone marrow. There are some malignancies that occur in the bone marrow. Some malignancies in the secondary lymphoid tissues, such as lymph nodes, and in other areas like gut or mucosa-associated lymphoid aggregates. For the T lymphocytes, some of the malignancy will occur in the bone marrow, and the other malignancies will occur in the another primary organ, which is the thymus, and also in secondary organs like lymph nodes or mucosa-associated tissues, and of course of the skin, which is very common with the T lymphatic malignancies. And as a revision, the central lymphoid tissues for the precursor B cells, they will be progenitor and pre-B cells. This is the patient will suffer from acute leukemia and the lymphoblastic phase of lymphoma, which will be dealt as if it is acute lymphoblastic leukemia. But when the cells becomes mature and it go to the interfollicular area and migrates to the SPD, to the lymph node, it first will form what's called the naive B cells, which will form a short-lived plasma cells without maturation inside the follicle. And from this kind of cells, which is called the pre-germinal center cells, some of the malignancy can occur. Of course, the most important of them is CLL and SLL, and its cousin, which is the mantle cell lymphoma, our today's lecture. But inside the follicle, there are another forms of malignancy. The most important and abundant find of them is the type of them is the follicular lymphoma, but some of the diffuse large B-cell lymphoma occurs inside this because a lot of changes occurring inside the follicle. The last one, after the follicular area has been formed, and the cells goes out, another kind of malignancy, some of the CLL can occur, and of course the marginal zone lymphoma, and those cells with plasmacytic differentiation, because these cells now becomes formed into plasma cells. So lymphoplasmacytic lymphoma, plasma cell myeloma, and similar diseases, what we are calling plasma cell dysregulation. These are the kinds of lymphoma that occurs. For the non-Hodgkin lymphoma, our series in this last few weeks, start if the cell under the microscope is larger cell, you will define them if either they are CD5 negative and CD10 positive, then it is a follicular lymphoma or diffuse large B-cell lymphoma. Of course, not follicular because it is larger cell. It will be diffuse large B-cell lymphoma, non-germinal germinal center type most commonly. But if it is CD10 negative, it is mostly non-germinal center, and we have discussed this before. But if it is CD5 positive, it may be a small cell that goes into a more aggressive form. For example, the mantle cell lymphoma that we will discuss today, the kind which is called pleomorphic mantle cell lymphoma, which will be Cyclin D1 positive, but it will not be small as usual as mantle cell lymphoma, which is usually small, but it will be large. So it will be gathered here with the larger cell. But now we found that it is CD5 positive. So it is a very important marker, CD5. Further differentiation of the diffuse large B-cell lymphoma is not important because it depends on the Epstein-Barr presence or human herpetiform virus number 8 differentiation or ALK presence or absence. These are rarer forms and not common forms of large B-cell lymphoma. We will come to this. We finished the diffuse large B-cell lymphoma in early lecture, and but for this some subclasses we will discuss inshallah later on. For the small cell lymphomas, we will found this map, which is extremely common. When we found a lymphoproliferative disorder with lymph node enlargement, we will do CD19. followed by CD5, CD19 positive, and CD20. This means that this cells is lymphoma cells, and it mostly non-Hodgkin lymphoma. So we will do CD5. If CD5 is positive, we will face 1 or 2 cells, because the small cells CD5 positive is 1 of 2 cells. Either it is chronic lymphocytic leukemia or it is a mantle cell lymphoma. Because if it is CD5 negative and CD10 positive, this is a follicular lymphoma we finished before. These are the map or repertoire of the small cell lymphoma. The hairy cell leukemia will be discussed next week, inshallah, and we finish the marginal cell lymphoma and mantle cell lymphoma today. So what will remain? The remaining will be chronic lymphocytic leukemia. And here it will not called chronic lymphocytic leukemia, rather it will be called SLL, small lymphocytic lymphoma, because they are twin disease, as we all already know. But I will make it into special lectures dedicated for CLL, because CLL is extremely common disease, and CLL is the most important, and a lot of new outcomes and a lot of understanding has occurred to the CLL. So I will keep the last one of the small cell repertoire will be discussed alone, as CLL will be managed into more than one lecture. But the next lecture, inshallah, we will continue with the hairy cell leukemia. So small cells, as we have said, it's either CD5 positive, these may be CLL and maybe mantle cell lymphoma. For the CD5 negative and CD10 negative, it may be hairy cell leukemia if CD103 is positive, like the next week. If CD013 negative, it may be mantle cell lymphoma or pro-lymphocytic leukemia, will be discussed later, inshallah. So we will continue today with the upper half of this difficult map. We will depend on the upper half alone now. Today we are dealing with the CD5 positive cells. This is, I think, this table we all know, and we all know it, how difficult it is before, but now I think it becomes more easy. Today we are dealing with number 2, mantle cell lymphoma. It is 19, 20, and 22 positive, because this is common lymphoid markers, but it will be CD5 positive, similar to CLL, but it will be CD23 negative, in contrary to the CLL. So the most important differentiation here is between mantle cell and SLL, and we will come to this into more and more details now. But I want you to remember, this graph is no longer, or this table is no longer a problem, because when you remember H1, which is more specific, you differentiate between CLL and mantle cell. You do not differentiate between mantle cell and follicular cells. There are 2 different diseases, depends on the origin cell. The CLL and mantle cell occurs in the pregerminal center, but follicular cells inside the follicle. It will acquire CD10, which is negative in SLL and mantle cell. And CLL and mantle cell will have a premature form of marker, which is a T cell marker, which is a CD5. And the CD5 will be negative in follicular cells. So I want you to become more and more deep into understanding what is meant by these markers. They are not just rehearse them as if they are like this, because you know when this marker occurs, and then you can understand what is the difference between disease. This graph represents a specific area of lymphoma. This is a peculiar area of lymphoma in which the boundaries between lymphoma and leukemia disappears. Previously, we gave this example in the first early lectures. What is the difference between lymphoma and leukemia? Leukemia is presence of the malignant cells in the peripheral blood. And this is very peculiar for hematological malignancy. No other malignancy will see malignant cells escaping and proliferating inside the peripheral blood and increasing in number of peripheral blood. Yes, they can circulate and they can be catched, but this is very rare, because these cells escape very rapidly to the tissues of secondary, for example, breast. But in cases of hematological malignancy, especially B-cell lymphoma, we will find some kind of this lymphoma occurs in the peripheral blood, and we call them a leukemic kind. Some of them may be in aggressive lymphoma, may be lymphoplastic, so the patient will have an ALL-like manifestation, and some of them maybe have an indolent disease. One of these indolent disease is CLL. CLL is a leukemic, and the count in the peripheral blood is very high. But at the same time, it is indolent, and the patient may live with this count for many, many years, and sometimes do not require treatment at all. and one of them is a mantle cell also sometimes comes with leukemic phase. And even the hairy cell sometimes comes with a leukemic phase. So means the presence of leukemic phase doesn't always mean bad thing. And as we will see today, that the leukemic form is actually a good thing. It is not a bad thing as we may think. So the presence of leukemic phase, that's to say peripheral blood malignant cells, doesn't always mean bad thing, as we will see. Today we will discuss only the MCL leukemic phase number 3 from the left. For the medium-sized cells, these cells may behave like malignant large cells, may behave like small cells, but as we increase in size, the cells becomes more and more malignant. So these cells with CD5 positive intermediate cells is usually CLL with pro-lymphocytic form or mantle cell with blastoid form. Usually they have a bad outcome. For the CD5 negative medium-sized cells is something related between Burkitt's and some of kinds of diffuse large B-cell lymphoma. It is not our discussion today, but we are now discussing only the CD5 positive cells, and it is not a CLL, it is a mantle cell lymphoma. For the cutaneous B-cell lymphoma, we will gather with the T-cell lymphoma because it is commonly cutaneous, most commonly cutaneous, and here we will discuss this some kind of a cutaneous B-cell lymphoma because it is presented by cell. And this form of plasmacytosis in the bone marrow, we will discuss with the plasma cell dyscrasis. So by this, we will finish all of the lymphoproliferative disorders, inshallah. One kind of this other arm of lymphoma, which is the Hodgkin's disease, also will have a lecture for this. But our systematic study was to study the most important and the most common at first. The most important, the most common at first. We first discussed the most abundant kind of lymphoproliferative disorders ever, and the most common form of lymphoma, which is a diffuse. Then we followed by follicular and marginal zone, and then we will now discuss the mantle zone, mantle cell lymphoma. Now this is the most common kind of lymphoma. So today we will discuss one of the lymphomas with a small size cell is the mantle cell lymphoma. So mantle cell, now we will ask like in previous lecture, what is mantle? What is the mantle cell? So this is our first to describe this kind of cells. So what is mantle and what's mantle zone lymphoma? Mantle means shield او درع، يعني الدرع او الاحاطه احيانا بتطلق على البلطو او اللي هو الجاكيت. So mantle means something that protects. So the lymphoma, lymphoid cells that will undergo somatic hypermutation and immunoglobulin switching in the somatic hypermutation and immunoglobulin switching in the dark zone of the follicle need some things that surround it, which is the early cells that will go inside the follicle. These cells that surround the follicle is called the mantle cell. So as we have said before, the mantle cells are immature cells, are mature cells, but naive. They didn't go into the follicle yet, still carrying CD5 positivity, never carried CD10 positivity, still outside, and it will carry some clinical picture of the mantle area. Sometimes it's called like corona, and we all know this corona becomes a bad word. In my childhood and early adulthood, corona was a good thing because corona is a kind of chocolate which is cheap. So I think that corona, يعني some of you يعني may remember this kind of still present corona chocolate. But once 2010 comes and the corona becomes not a good thing, and we understand what is meant by corona. So still it can be called a corona kind of cells, and it contains transient lymphocytes, as we said. This is naive or early mature cells that will go inside the lymphoid follicles from the sinuses, and they will go inside the follicle to continue the manifestation. If something happens to these cells, it will not continue the duration, and rather it will proliferate and forming one kind of bad kind of lymphoma, which is a mantle cell lymphoma. The area surrounding it is called the marginal zone. It's much more and more immature, and sometimes of them are mature because it is the outside of the follicle. And outside of them is the kind of cells which is the mostly T cells, which is present in the medulla of the lymph node. So this is the cortex of the lymph nodes. We understand that from most inside is the germinal center dark zone. Around it is a germinal center light zone. Around it is a mantle zone. Around it is a marginal zone. Then all of this is surrounded by the medulla, which contains mostly T lymphocytes and small amount of T lymphocytes. As we have said before, the germinal center is already composed of two kinds. Dark zone and light zone, the mantle zone followed by the marginal zone. Here it appears much more in the context of a whole clinical picture. This cyan color, which is the medulla, which medulla contains mainly T lymphocytes, as we have said before. So this is the mantle cell, and we understand what's the kind of this mantle cell. What is normally it occupied by, what is the cells that occupy mostly this area. Now we will talk about a mantle cell lymphoma, and we have said this is one of the abundant kind of lymphoma. It's present about 6%, and after diffuse large B-cell follicular lymphoma and Molt lymphoma, which is some kind, Molt lymphoma is the marginal zone. Yani we mean by Molt lymphoma is a marginal zone lymphoma. Yani. SLL and CLL, and I've said we will skip this kind and we will make it with CLL because CLL needs a lot of discussion. And today we will discuss mantle cell lymphoma. For the Burkitt's lymphoma, I may skip also. And for the T cell, I will make a special lecture with the B cell skin lymphoma. So by this, we will finish non-Hodgkin lymphoma. A special dedication will be for Hodgkin disease or Hodgkin lymphoma. Hodgkin lymphoma will be discussed into more one than lecture because it is also important because nowadays it has a lot of treatment, especially transplantation and CAR-T. So mantle cell lymphoma comprise about 3 to 6% of newly diagnosed non-Hodgkin lymphoma. It's not too much, it's not too little, and it is small to medium sized. The small one is the monomorphic, except the polymorphic variants, which is an intermediate size, and it is a heterogeneous type of non-Hodgkin lymphoma, some different outcomes, and mostly it possesses unfavorable characteristics for both indolent and aggressive disease. So it is not that good, and it's not that bad. It is something in between, as we will see now. Before it was called synthetic lymphoma because it is maybe in the center and it is formed of small cells and synthesites. It may be lymphocytic lymphoma of intermediate differentiation, and it may be sometimes called the mantle zone lymphoma. And we found that nothing is called mantle zone. It is not like a marginal zone. It is not a zone. It is a mantle cell. It is something called the cap, but it's actually it's not a zone of the lymphocytes of the lymph node. So all of these names becomes obsolete, and this kind of cells are malignancy. It's called mantle cell lymphoma, and it's abbreviation, international abbreviation in MCL, not marginal zone MZL. MZL or MZL is a marginal zone lymphoma, but MCL is a mantle cell lymphoma. And I know a lot of my colleagues and a lot of fresh graduates may mix together. Sometimes when I was fresh graduate, I mixed between mantle zone and mantle cell and the marginal zone. But that time was not that problem. يعني كان ساعتها لسه Rappaport classification WHO wasn't that famous. Yeah. The pathogenesis of mantle cell lymphoma, it is very similar to that of the CML. Very similar. It is caused by a reciprocal translocation, balanced translocation between chromosome 11 and chromosome 14. Chromosome 11 transfers something to chromosome 14. The short one carries always a bad outcome. So this short chromosome now, they're having two important genes beside each other. The immunoglobulin heavy chain promoter area, which is this very strong area for promotion of gene stimulation, and beside it to bring Cyclin D1, what thing of the cell, of the markers that will, of the genes that will stimulate the cell cell multiplication. So we will bring the fire beside the fuel, and this will make this fire, this kind of malignancy, because of this very bad translocation 1114. So 1114 will bring the Cyclin D1 gene beside the promoter area of immunoglobulin heavy chain gene on chromosome 14. These two chromosomes are very famous, 11 and 14. This will come and appears with us in hematology many times. So concentrate, but the mantle cell lymphoma is caused by these translocations that bring this kind of gene, Cyclin D1, besides this kind of gene, immunoglobulin heavy chain on chromosome 14. So this is the pathogenesis of mantle cell lymphoma is due to this translocation, and obviously the cyclin D1 will be overexpressed in this condition. This is what is called the cell cycle. The cell is present in what's called G0 or resting state, but once it is stimulated to start multiplication, it will go into a cycle called the cell cycle, in which it will multiply and increase its genetic material, increase its cytoplasm, and hence start to cause some mitosis division at the M phase, and then after that it may go again into the G0, becomes quiescent and doing nothing. And this is controlled by things that stimulate the cell cycle and things that inhibit the cell cycle. One of the important stimulators of the cell cycles is the cyclin. Cyclin is a protein which stimulates the cell cycle, especially in the G1 phase. And it will stimulate what's called cyclin D kinases. So cyclin D kinase depends on cyclin, and this cyclin has carry many letters and numbers. We have cyclin A, B, C, D, E, and most important of them is the cyclin D. And cyclin D, there are many isotypes of it, cyclin D1 to 3. And this cyclin D1 and the 3, especially cyclin D1, which is extremely important because it stimulates the kinase number 6 and 4 in the G1. This will lead to firing up of the multiplication, and this will stop the apoptosis, as we will see. So the cyclin D1, if it is overexpressed by 11-14 translocation, this will lead to very strong multiplication process, and hence there will be malignancy. And this malignancy will also stop the apoptosis. And hence this process will, at the end, will lead to proliferation and leading to formation of this stubborn malignancy that doesn't respond to any medication, because you have a very strong process of stimulation. Cyclin D1 will not stop because it becomes near to immunoglobulin heavy chain, and it is continuously produced. So overexpression of cyclin D1 is the most important cause. How it is produced and overexpressed? It is overexpressed because of the translocation 11-14. In very rare cases, because we are dealing with biology, we are not dealing with mathematics. We are dealing, إحنا مش هندسة. Doctors are not mathematicians. This is a very big problem in the community. Community thinks us like mathematicians. We are not mathematicians. There will always be exceptions. So one of the exceptions in mantle cell lymphoma is that sometimes cyclin D1 is negative, but it may harbor the translocation, and it may harbor disease in cyclin D2 and D3. Remember, cyclin D2 and D3 plays as exactly like cyclin D1. So the absence of cyclin D1 translocation 11-14 doesn't mean that this is not a mantle cell. It means it is a mantle cell. If it is CD23 negative, CD22 is positive. So if it doesn't look like CLL, but at the same time cyclin D1 is negative, don't bother. It may be cyclin D2 positive. And cyclin D1 negative, though it is rare, but it still carries the same risk and the same pathological features and same treatment as the cyclin D1 positive. So cyclin D1 negative MCL is present, but it is not that common, number one. Number two, it is delta as if it is mantle cell cyclin D1 positive. And the number three, it may be due to cyclin D2 mRNA overexpression by 55%, or cyclin D3 even. So the absence of cyclin D1 doesn't mean that it's not an MCL disease. What are the types of the MCL? We have the classical MCL, which is maybe nodal or extranodal, that comes into a lymphoid, that comes in the nodes or comes outside the nodes. Number two is the leukemic and the non-nodal MCL. And here it may look like CLL. Remember, it is a cousin of CLL. I told you in the beginning of the lecture, this is the cousin of CLL. زي الCLL بالظبط. فليها leukemic phase, and this leukemic phase non-nodal, doesn't come in the nodes and comes only in the peripheral blood and infiltrating the peripheral blood. Number three, something called in situ mantle cell neoplasm or ISMCN. This is some kind of pre-malignant diseases. The era today in this century is a pre-disease, not the disease, it is a pre-disease. If there is a predisposition of the disease, like a pre-diabetes, a pre-hypertension, and even we have a pre-malignancy. This pre-malignancy, like in situ mantle cell neoplasia. Something like in situ cervical neoplasia in cases of cancer cervix. If a patient have in situ malignancy, this means that it may develop cancer cervix and must be treated well. But this is not the same thing here in mantle cell lymphoma, and we will understand why. the presence of in situ mantle cell neoplasia doesn't mean that the patient will develop mantle cell lymphoma or any kind of lymphoma. So here again, the mantle, the naive cell, which comes from the bone marrow, harboring this translocation 11 protein. So a lot of this, there must be a question that arises here. What brings 11 protein translocation? So any speculation about this? I think most of us ask himself, what brings 922 in CML? What brings 1114? What brings 8 translocation in Burkitt's lymphoma? These things we do not understand why this happens, because this is a lot of things. But we know that some patients harbor this chromosomal instability. Some patients may be exposed to some chemicals and some irradiations that will lead to this kind of translocation. But still, no answer about this question actually in the literature. There's no answer. Why this patient exactly has this translocation and this patient doesn't have, we don't know. Some of the cells later on, after pressure of this translocation and the multiplication, new genetic will be acquired. This is an evolution of the disease. The new genetics will be acquired, like TP53, and all of us know that the TP53 mutations carries a very bad risk in all kinds of malignancy. And also some of the chromosomal loss, like P1, like Q6, like 13q, like 3, like 18, and this will lead to blastoid and pleomorphic formation. So the mantle cell lymphoma also may be under the proliferation pressure, and the evolution of the disease may develop into a more and more aggressive kind of disease. Again, the cells that will go into naive may have this translocation 1114, and then it will go into one of two mechanisms. Either it will go inside the follicle, and hence it becomes having immunoglobulin heavy chain mutation, and it will form the non-nodal leukemic form, or it will still stay in the mantle zone and in the extrafollicular area, and here it will form the blastoid transformation. This is the map of what will happen to the translocation 1114 if it is not treated, or what is the pathways of this kind of tumors. Either form the classical form or may form the indolent non-nodal leukemic form. So what is the formations of the what is the kind of types of mantle cell lymphoma? The first one is the classical, and the classical form or the nodal form, we have two kinds of nodal form. The first form is called the classical. So the nodal form, we have three types of mantle cell lymphoma: the nodal form, the leukemic phase, and the in situ malignancy. For the nodal form, we have two formation or two steps. The first step is called the classical form, in which there is immunoglobulin heavy chain is unmutated, and this is logic because these cells didn't enter the germinal center. It will not have immunoglobulin heavy chain hypermutation or somatic hypermutation, as we call it, and we discuss this in more details in the development of B cells lectures. Number two, it is generally aggressive, and number three, and it is extremely important, that it is SOX11 positive. What is SOX? SOX is a transcription factor that will lead to oncogenic drive. It will suppress apoptosis, and it will promote angiogenesis, and it is present in about 80 to 90% of cases of classical MCL. So now in classical MCL, we have two important markers and genetics. The first marker, that it has translocation 1114 or Cyclin D1 overexpression. Number two is that it is present in SOX11 positivity. And that's why this classical MCL is extremely bad prognosis. And this explains for you, لما دايما الناس تقول لك mantle cell, although it is a small cell, it is very bad prognosis. Why? Because it carries two important genes that promotes the proliferation and prevents the apoptosis. One of them is the Cyclin D1 due to translocation 1114, and the second is the SOX11 positivity. Under this pressure of this genetic strong mutation, some mutation, another mutation occurs, as we have said, that mostly loss of some of the chromosomes, like 1q, like 3q. Similar things will happen in myeloma. Inshallah, when we discuss myeloma, we will see some things like this, something of the development of more aggressive myeloma that occurs due to loss of a lot of the chromosomes. This instability in the chromosomes will lead to uncontrolled proliferation without possibility to treat. The blastoid form will behave like becomes a large, intermediate size, larger size, and it behaves like diffuse large B-cell lymphoma, and will acquire more Ki-67 proliferation index. So it will be highly proliferating, not indolent like the classical form. It will be aggressive. It will be large cells, and at the same time, it will not be chemosensitive, للأسف, like the classical diffuse large B-cell lymphoma. It will be similar to the ABC form of the activated B-cell diffuse large B-cell lymphoma, if you remember. So it will carry the worst things of both. It will become very aggressive from the form of the large cell, and at the same time, it will acquire the resistance to chemotherapy like a small cell. That's why this mantle cell lymphoma has this bad reputation. It has bad reputation. Why? Because the blastoid and pleomorphic and the classical forms carries very bad genetics that will make it proliferate and mimic into blastoid and pleomorphic form, and at the same time, it will carry the chemoresistance characteristics that of the small cell. So the classical form is not that good. Though the classical form, you will not find any peripheral blast. You will not find any peripheral lymphoid cells. All of them are nodal and infiltrating the tissues, of course. The second kind of mantle cell lymphoma is called the leukemic or non-nodal subtypes. And when we call anything leukemic, means that the peripheral malignant cells is present in the peripheral blood. And it is typically SOX negative. And it's typically immunoglobulin heavy chain mutated. And it's usually indolent disease course. Although it is leukemic, it is indolent disease. And it commonly presents with peripheral blood and bone marrow and splenic involvement. Though it is not that malignant and it's not that aggressive, similar to that mantle cell lymphoma, which comes with nodal, with SOX11 positivity and translocation 1114. Still, this kind of malignancy is 1114 positive. This is a universal for all kinds of mantle cell lymphoma, 1114 and Cyclin D1 overexpression. But it is a SOX11 negativity, so it will not behave similar to that of SOX11 positive, which become pleomorphic. The tumor burden and the proliferation index is low. So you will find that the peripheral blood count maybe 20, 30, 40, something like this, and a little bit anemic and thrombocytopenic. And it is of low burden, and it doesn't cause large burden tumor volume, and at the same time, it's not that malignant, similar to that of the nodal form. So what is the clinical picture of mantle cell lymphoma? Usually mantle cell lymphoma presented by stage 4. So the nodal form, we mean the classical and the nodal form, in which usually it infiltrates organs, either liver, either bone marrow at the start. So it is a bad prognosis from the start. It doesn't come with stage 1 and 2, rarely. But nowadays we now diagnose mantle cell lymphoma in stage 1 and 2 because of the more and more patients are caring for themselves, making examination. The aggressive form SOX positive is nodal presentation, and the indolent form will come with leukemic presentation, which will appear in CBC. More and more patients now are doing CBC. So you can diagnose this very easily. The patient may present by generalized lymphadenopathy, hepatomegaly, splenomegaly, the peripheral blood in the leukemic non-nodal form, multiple intestinal polyps, lymphomatous polyposis in the nodal form and non-nodal form. The progression to blastoid and pleomorphic variants that occur with the classical form and in relapse in 22%, and sometimes it will transform into diffuse large B-cell lymphoma. Initially, we will do the as classical examination. We will do CBC, we will do H, uric acid, beta-2 microglobulins, hepatitis B and C, because it is related to the hepatitis C positivity. Of course, with the good clinical examination and good history. We will do, as usual, bone marrow biopsy, because either it is stage 4 nodal, it will be infiltrating the bone marrow, or either it is leukemic form, it will infiltrate the bone marrow and can be diagnosed by bone marrow. We will do lumbar puncture because the cells can also go into the CNS. We will do PET scan, we will do CT scan for the neck with contrast if clinically indicated. We will do CT chest of the whole body if it is indicated, according to the lymph node involvement. Of course, we do echocardiography and the cardiac consultation, because it is very important, because we will give a hell of chemotherapy. كمية كيموثيرابي هتبقى كتير قوي، وبالتالي it is important to do the cardiac manifestation. If the patient has GIT manifestation in the form of malabsorption, in the form of vomiting, in the form of diarrhea, then the patient needs to be examined for the GI involvement. And we found that 80% lower GI and 43% upper GI involvement, mostly microscopically. And the only 4% that yielded biopsy led to altered management. So it is not important to do in mantle cell, in all mantle cell lymphoma, GI examination and biopsies. Only if the patient has manifestation, because it is infiltrating, it is stage 4. Usually it presents with stage 3 and 4, usually infiltrating all of the body. So there is no need for routine endoscopy or colonoscopy for initial workup, only if the patient, as we have said, is coming with a stage 4. And sometimes if you are in doubt and you think that the patient is stage 1 or 2, and you need to be sure that he is not stage 3 or 4, so you to be sure that he is only stage 1, and you need to be sure that he doesn't have lymph nodes, or in the PET scan appears some brightness. So sometimes you need to do colonoscopy and take a biopsy. But I think we do not need to do this yet. The diagnosis is to do histological examination or flow cytometry if it is leukemic, and we will come to the genetic, of course, translocation 1114, Q13, Q32, and take care when we pronounce the genetics, we don't say Q13. It is Q13. This is the band and subband, band number 1 and subband number 3 of the long arm of the chromosome. So it is not Q13, it is Q13 and Q32 for chromosome 14. This Q32 of the chromosome 14, you must remember very well, because that is immunoglobulin heavy chain gene. So in this position. So when Q13 of the chromosome 11, which carries the Cyclin D1, comes beside Q32 at chromosome 14 of immunoglobulin heavy chain promoter, this will lead to the increased presentation or increased expression of Cyclin D1. Now we can concentrate to take this slice of this NCCN guidelines graph. This is small cells. We will do ban B cells because it appears under microscope as a B cells or lymphocytes. We will find it site CD5 positive, and it is CD23 negative, not positive. If it is positive, it will be CLL, and it is CD23 negative. We will do Cyclin D1 markers. It will be extremely positive, or translocation 1114 is most important to do the translocation either by PCR or by FISH or by NGS, whatever the things that you will have in your facility. Then it will be diagnosed as a mantle cell. For the intermediate cell also, if it is CD5 positive, you will do Cyclin D1 if it is positive. So it is a mantle cell lymphoma, but not classical form. At that time, it is blastoid form. And here, the immunophenotyping, now we can concentrate on the immunophenotyping of mantle cell. It is 19, 20. 22 is markedly positive, but still 22 is positive in CLL. So you cannot depend on 22. And 23 is extremely positive in CLL and extremely negative in mantle cell. And Cyclin D1, of course, positive in Cyclin D1 is positive, of course, in mantle cell, and the negative in CLL. The BCL2 is positive in both, so it is not, we cannot depend on this. So 23 is negative in MCL, positive in CLL, SOX positive, 11 SOX positive in MCL, Cyclin D1 is positive in MCL, and both of them are negative in CLL. So the things that will differentiate between them is the 23 and SOX 11 and Cyclin D1 presentation or expression. And the MCL leukemic phase, as we have said, the white blood cell count usually between 10 and 30, and it is diffuse interstitial to number trabecular aggregates in the marrow, and it is usually indolent form. And we have said that it is site CD5 positive, 23 and 10 negative, 103 negative because it is not hairy cell leukemia, and of course Cyclin D1 and BCL2 positive. BCL6 negative because it is not follicular, it is from outside the follicle, so BCL6 is negative. There's some pitfalls in immunohistochemistry because Cyclin D1 immunohistochemistry is not that important. The most important is the translocation. Sometimes some cells are Cyclin D1 negative, and at that time Cyclin D2 and D3 may be positive. SOX11 is very important. And immunoglobulin heavy chain, sometimes it is important to do if it is becomes non-leukemic phase. It is will be immunoglobulin heavy chain will be positive. The Ki-67 proliferation index is important. If it is more than 30%, it is bad prognosis, and usually it is related to the plastoid or polymorphic forms. TP53 is very important because it is linked with very poor prognosis and usually associated with Ki-67 high level, more than 30%. It is associated with blastoid morphology, with shorter survival, with chemoresistance. This is TP53 mutations is very bad in anything. In CLL, due to 17p deletion. In AML, it is associated with chemotherapy-related acute myeloid leukemia, very resistant to chemotherapy, and here in mantle cell, it is very resistant to chemotherapy. So this is one of the kind of important cells that you will always remember in the exams, in the life, when we treat leukemias, lymphomas by any way. Remember always TP53 because its mutation always means a sentence of this for a patient, because it will not respond to any chemotherapy. The prognostic index, as we see that mantle cell lymphoma lies between indolent and aggressive forms. It is not indolent, it is indolent by the shape, but it's aggressive in the behavior mostly. And according to the Mantle Cell Lymphoma International Prognostic Index, which includes age, performance status, LDH, upper normal increase, white blood cell count in the peripheral blood. So, if the patient has low risk, the patients will be, if the patient has low risk, is the blue line. His survival is very good, but the patient with high risk, the survival will be very bad. With the high risk, the survival will be very bad. So this, we now understand the diagnosis and the prognosis. This is the treatment options, and the treatment option actually depends on many things. But the most important thing that will depend on the treatment options for this mantle cell lymphoma is actually the condition of the patient. If the condition of the patient is good, a lot of things can be offered. This is very similar to any malignancy, طبعا. But if his condition is bad, I think the options becomes less, especially if he is in aggressive form. The options will become less. This is one point. The second point is the stage, and we have said before it is mostly stage 4. So usually in stage 4 he needs strong chemotherapy, aggressive chemotherapy. Number 3 is the TP53 mutation. If it is positive, this means that even strong aggressive forms will give outcome very bad. So I may think for consolidation after the aggressive therapy very rapidly, because if he has TP53 mutation, he needs strong consolidation. مش هينفع من غير consolidation. Another rule in this malignancy, this peculiar malignancy has some rules that we will see. We have maintenance. We don't hear a lot of word maintenance in cases of lymphomas. صح؟ في lymphomas ما نسمعش عن maintenance. دايما chemotherapy, and then after 6 cycle we'll see if it is in remission, in partial remission, in no response. But no, we don't hear about remission in maintenance too much, or consolidation. These things we hear in leukemias only. This maintenance and so because it is this kind of malignancy lies between the categories, a lot of categories of malignancy, because it is aggressive as well as it looks indolent in some kind. So it behaves like this. So maintenance gives a good result in it. Also, second line and subsequent therapy have a lot of trials. مهمة. We will come to this now. So the key consideration of induction therapy, this induction therapy, and is that no randomized trials, no big randomized trials. We have only preferred regimens, we other recommended regimens, we have aggressive regimens, non-aggressive regimens according to the condition of the patients. But as a rule of thumb, if the patient's condition is good and the patient requires a treatment, he's not a stage 1, he's not leukemic phase, he's nodal, he has translocation 11-14, he has SOX11 overexpression, and he has a lot of tumor volume, he is intermediate or high risk, this patient will need chemotherapy. And this chemotherapy will not be small chemotherapy or low dose chemotherapy or less aggressive chemotherapy. It must be very aggressive. It must be consolidated and it must be maintained with treatment, because this disease is not responding, similar to the CLL. It is not curative. And at the same time, it is very aggressive. It can aggressive into blastoid form, into diffuse large B-cell lymphoma, or it may acquire TP53 mutation. So you must be very cautious, especially if the patient is good condition, because he has a trial to be a little bit good survival. So what the choice of treatment depends on disease stage, TP53 status, comorbidities, and the transplant eligibility. So stage 1 and 2, it is not common. The disease itself is not common. It is between 3 and 6% of all non-Hodgkin lymphomas. So it is not that common. Yani. Number 2, stage 1, 2 is not common within this uncommon disease. So it is not common. You will never see this in stage 1 or 2, never. Yeah, in Egypt, I never see this disease in stage 1 or 2. Usually stage 3, stage 4, very infiltrating everywhere, and sometimes CNS. So there's no limited data. If there's stage 1 and 2, and you are sure, and you do biopsy from the colon, and there's no polyposis, so at that time, you can observe, you can give irradiation if it is stage 1 on like Hodgkin disease, and sometimes you can give less aggressive chemotherapy that we will see. So stage 1 and 2, this is not common, and you can wait and see. And waiting and see is similar to the less aggressive chemotherapy, because both have the same overall survival. But as we have discussed before, it is not possible to have a patient coming with lymphoma and you don't give anything. This is politically is not quite well, not correct. Yeah. Usually you will give chemotherapy, especially if you are not extremely sure that is a stage 1 or 2. How much you can be sure? You didn't do colonoscope, you didn't do endoscope, you are not sure 100% is this not a stage 3. Means infiltration in both sides of the diaphragm. So I think it's practically wise that mostly the patient will take one of the less aggressive chemotherapy, like bendamustine rituximab, BR. It is a very good regimen in this disease, and it has been tested in many trials, and it is very one disease, less toxic, not similar to other disease. And also you can add one of the TK inhibitors, like acalabrutinib continuously with the BR. And sometimes we give some diseases, some medication similar to the other lymphoid disease like myeloma, like bortezomib, with a cyclophosphamide doxorubicin. And so it's like bortezomib, Velcade, CHOP. Or you can give R-CHOP, you can give lenalidomide rituximab, similar to myeloma. So they will have similar, because it is a non-curable disease. You give some things that can be taken in malignancy, benign malignancy, in a very long duration, that you can hopefully find to decrease the cell's load step by step, similar to myeloma. Yani. You use Velcade, you use lenalidomide, similar to myeloma, because they are similar in many things. Other recommended, you can take acalabrutinib and rituximab, and looks like this regimen for the frail and old age patients who cannot withstand the BR chemotherapy. So stage 1 or 2 either involved site irradiation, or if he is a stage 1 or stage 2 non-bulky disease. If it is bulky disease, you cannot give involved site irradiation alone, or you cannot make watch and see. You give just a less aggressive therapy. So stage 1 or 2 non-bulky, continuous or non-continuous, contagious or non-contagious, I'm sorry, classical TP53 wild type, with stage 2 bulky or stage 3 or 4, you can use less aggressive therapy, like acalabrutinib, bendamustine, rituximab, VR-CAB, R-CHOP, lenalidomide, and rituximab. I think R-CHOP is a good option in these patients. All of us is familiar with, and you can use it very good. If you have the money and you can support the patient to use acalabrutinib, it's okay. You can use acalabrutinib in this with the bendamustine rituximab. It will be very good option. In the advanced stage, majority requires heavy chemotherapy, not easily chemotherapy, not intermediate or less aggressive chemotherapy. You must need very aggressive chemotherapy. And here you think that the patient is TP53 wild type. This patient, you will think of transplant eligibility, because you can have some element of cure or very long complete remission. If he has TP53 mutated, it is better to go into clinical trials if your country supports clinical trials, because this patient, even with transplantation, will not respond. because this TP53 is very bad prognostic outcome للأسف if it is mutated. So here we are treating more the TP53 wild type, not the TP53 mutated type, because the mutated type is usually will have very poor outcome. So in this kind of patients or TP53 wild type and stage 2 or stage bulky disease with contagious or non-contagious and special and stage 3 and 4, this patient will not take the usual chemotherapy, R-CHOP, bendamustine R. You must give a strong chemotherapy. Strong chemotherapy like rituximab, dexamethasone, cytarabine, plus platinum. The very famous protocol, RDHAB. This is very old protocol. We've been used many years ago when I was fresh graduate ولسه starting my residency. Use this RDHAB, but it is very toxic to give this RDHAB. We can use MaxShop with very high dose of cyclophosphamide. Sometimes we use a regimen called triangle regimen using R-CHOP because alternating with ibrutinib and RDHAB. So I think this is very aggressive chemotherapy. Not all patients will withstand. Or some people are using hypercivet. All of us is familiar with, and we can use. Usually in our department, we are using hypercivet because it is well known. We treated all of the leukemia with it, and the patient with mantle cell lymphoma is not like leukemic patient. He can a little bit withstand the hypercivet, and the outcome with it is well known and well tried. So I think hypercivet is a good option if you are the patient is fit and he is transplant eligible. You can give hypercivet, and when he goes into complete remission, you can consolidate with a stem cell transplantation. The less aggressive we have told you before. After this, you can maintain. We can maintain either by ibrutinib and rituximab. We will come to this just right now. You can consolidate by autologous stem cell rescue, followed by maintenance either by rituximab or by BTK inhibitor. So maintenance is a good thing. So it is not only induction, it is induction, consolidation, maintenance, something like leukemia, because it is very relapsing disease, it is aggressive disease, it goes into mutations, it is not responding quite well. So I think mantle cell lymphoma is, we have been told this since our early residency, that this is looks like small cells, but it's actually it is not a good kind of malignancy. It's very aggressive, similar to CLL, but it's not behaves like CLL at whatsoever. It behaves like aggressive kind of diseases, but looks small and naive. Yeah. Of course, as usual, when there is a relapse, there are a lot of things that most of them are not available, like covalent BTK inhibitor, acalabrutinib, or zanaprotinib. Non-covalent is used nowadays and will be tried nowadays, like pirtobrutinib for BTK refractory. If it is covalent BTK inhibitor resistant, like in ibrutinib, acala, and zanaprotinib, if it is resistant to all of this, we can use the non-covalent BTK inhibitor pirtobrutinib. It is not available in Egypt till now. Or you can use CAR T cell therapy. In ZUMA-2 trials, it is well studied, and both of kinds of CAR T are لهم outcome good with the mantle cell lymphoma. But it is important that in the CAR T not to give before it heavy transplantation. And this becomes a very important question. Yes, it is not in the Middle East. Still, we don't have CAR T therapy in even virtually all of the Middle East. But I think this is a problem in the international consensus, because you can give the patient some chemotherapy, but he will lose the possibility to do, because if he took too much aggressive chemotherapy, the outcome of the CAR T will not be good. So there will be a dilemma here, just to give heavy chemotherapy and go directly to the CAR T, or make the CAR T a second option. Still, this is not answered in the international trials. But I think later on, CAR T will become one of the first-line treatment in most of the malignancies, because why we go into different kinds of chemotherapies, and we can do CAR T with very good progression-free survival and outcome for the long run. What is the role of the transplantation? The transplantation is a good kind of consolidation. So it is not a kind of cure and for treatment, like it is similar to all of the chronic malignancies of lymphoproliferative disorders. Usually it is for rescue only. Autologous stem cell transplantation is a rescue for giving very huge doses of chemotherapy. So if the patient is very high risk, we can do allogeneic. If the patient passes into many lines and using the BTK inhibitors and even using venetoclax and enter partial remission or complete remission, we will do allogeneic chemotherapy. You can do auto stem cell therapy if he is young and fit and he has done already responded to the first line chemotherapy. You can do very huge dose of chemotherapy followed by autologous stem cell transplantation rescue and followed by maintenance either by BTK inhibitor or by rituximab. These are the most important 3 trials used in the mantle cell lymphoma: the triangle trial, Shine trial, and MCL younger. And in those, we answer many questions. If the transplant is good, if the use of the ibrutinib is good, if the or BR alone, the autologous stem transplantation ولا لا. يعني this trials we will take 1 or 2 of them just يعني for rapidly. The first one is a very important trial, actually, the triangle trial, in which we see the alternation between R-CHOP and RDF followed by stem cell therapy and followed by observation, or followed by maintenance for the second arm, or using ibrutinib and followed by maintenance of ibrutinib directly. So the first arm we use R-CHOP, RDF without ibrutinib, followed by stem cell therapy and followed by 3 years maintenance of rituximab. The second arm we use the same R-CHOP and RDF but with ibrutinib and then followed by stem cell therapy, followed by 2 years maintenance ibrutinib and 3-year maintenance of rituximab. Or another arm, which is the R-CHOP plus ibrutinib and RDF, followed directly by maintenance ibrutinib and maintenance rituximab without use of autologous stem cell therapy. You can find that the first arm, which is arm A, is the worst of all, while the arm B and the arm A plus I and the arm I are both good. So this raises a very important question. Is it better now to do transplant or not? I think the answer in the triangle trial is not. If you use R-CHOP, RDF with ibrutinib and then you maintain by ibrutinib and maintain by rituximab, there will be no need for use autologous stem cell transplant because the gray and the green color are actually the same. There's no difference between the gray and the green. The green one with the transplant and the gray color with the without transplant. Maintenance alone of ibrutinib. So, but if we didn't use ibrutinib either in the induction or in the maintenance, there is no good outcome. This is the blue one. So in the triangle trial, it gives a very important answer. Is the frontline or use of BTK with the chemotherapy is good? Yes, it is good. It can replace the transplant if it is used in maintenance? Yes, it can replace the transplant if used in maintenance. Another 2 important trials is the use of acalabrutinib and ibrutinib with the BR, with the bendamustine rituximab, followed by maintenance, and adding of the ibrutinib is good. So either adding of ibrutinib in the triangle trial on ECHO in Shine, or even in bovine trials like zanubrutinib, which can use in TP53 mutated cases, or in ECHO trials. So adding acalabrutinib or ibrutinib or zanubrutinib. Now we have many trials that used acalabrutinib, ibrutinib, and zanubrutinib in many regimens, and all of them gives rise that the important point that adding BTK is good in cases of mantle cell lymphoma. So mantle cell lymphoma is the cousin of CLL because CLL BTK make a paradigm shift, change in the management and outcome of CLL. Also in mantle cell, the BTK inhibitor becomes a very important cornerstone, and even it can ameliorate and it can remove the need for the autologous stem cell transplantation if they are used as a maintenance dose. The problem in these drugs is many problems. The first one is that these drugs are extremely expensive, and we have been discussed this with Dr. Maha شبهنا last lecture. It is very expensive drugs. The safety profile is good, but the disease may have something that elements that prevent continuation, like AF, like aggressive pancytopenia, like granulocytopenia, infections, like BT prolongation and the bleeding, and most of these patients are older patients. So the possibility that we can stop is very common. So it is very common that we can stop. So the idea here is we can see if the patient can withstand transplantation, and the cost to maintain for 2 years this drug, and after that sometimes it will continue on it like CLL. So we don't answer these questions yet. But when these drugs becomes a little bit cheap, I think the management of a lot of lymphomas will change. Yeah. For the relapse, we have this simpatico, like ibrutinib, venetoclax. Now we start to attack the apoptosis regimen, and we have said that SOX11 inhibits also apoptosis, and we can use even the bispecific drug glofitamab, CD20 and CD3 positive, that will enhance the activity of the T cells against these B cells, and all of these things in the clinical trials give good rise. Simpatico has been done for the TP53 mutated cases. Also, glofitamab, we try to this slice of patients who have TP53 mutations who are very bad outcome. We can try to treat them by non-classical kind of treatment, non-classical thinking, because the outcome is very bad. They will not withstand and will not benefit from chemotherapy and even with transplant. So this kind of patient needs another area of thinking. This is from a Canadian summary of the how to treat. For the fit patients, we use RDHAB, R-CHOP, or R-MAXI, CHOP, high-dose chemotherapy, followed by autologous stem cell transplantation and maintenance chemotherapy, or we can use R-Hypercivad with autologous stem cell transplantation. I think we can adopt this in Egypt and Middle East. For fit or for conventional doses, الناس اللي هم cannot withstand high dose but can fit for conventional doses R-CHOP, but better than R-CHOP is the PR. Bendamustine rituximab is very good, and if we can add some of the BTK inhibitor, it will be extremely good, like SHINE criteria. For the unfit patient, we can use PR alone, R-lenalidomide alone, BTK plus R alone with maintenance rituximab. I think maintenance rituximab is good in any patient who go into partial or complete remission. It will be good because it maintains the patients for a little bit. While for those who are relapsed, there's not a lot of options. Maybe if we go into remission, you can do allogeneic transplant. We don't have clinical trial للأسف حتى الآن. You can add ibrutinib. You can use mix between lenalidomide, bortezomib. Here you can find a lot of areas you can use according to the condition of the patients and the payer who can pay for him. This is, of course, this picture and this graph represent the pathways of inside the B cells, and we every now and then invent another drug. Now we can use BTK. We have two levels of BTK inhibitors. The first is the covalent level, which can inhibit BTK, but some cases are BTK resistant, BTK inhibitor for the covalent. Now we have ibrutinib, which is non-covalent adhesions. So we have some of other drugs like BI3K inhibitors we can use now. We have a lot of anti-CD20, we have anti-CD20, we have the bispecific. We have a lot of the drugs now which can be very good for the treatment of the B-cell lymphoma. These are the three forms of drugs that prevent. The Umbrovica is a ibrutinib, Prokenza is a zanubrutinib, and calcans for the acalabrutinib. These are the three common forms of BTK inhibitor covalent forms, and all of them are present. I think in Egypt, I think maybe Prokenza is present. I don't know if it is present zanubrutinib, but I know some colleagues they prescribe this drug. Calcans, of course, and Umbrovica is well known. Yeah. And of course, the acalabrutinib is the best of them because it is attack mostly the red dot, the big dot, which is the specificity. So I think the ibrutinib is hitting more than one enzyme and genes, so it has a lot of side effects because this is non-specific. Zanotibrotinib similar to protinib, but acalaprotinib is better in more specific than both of them. This is for the covalent kind of this disease. There was a very good video by Dr. Diego Villa, who wants to, it is about 1 hour, discussing again mantle cell lymphoma, but with more details about the treatment and in the treatment, the guidelines, and it gives in a more humble way and very good way the description of use of drugs according to the Canadian thinking. Yeah. For this, I have finished the lecture, and I thank you very much for this. And we'll stop streaming over the YouTube. And if any questions, as usual, we will continue inshallah here on the group. شكرا لكم وجزاكم الله خير.